Hello, and thank you for joining today's Quality Payment Program Year 2 Train the Trainer webinar. Today, representatives from CMS will present an overview of the Quality Payment Program Year 2 Final Rule Participation Requirements for CMS staff and its contractors. You can listen to the presentation through your computer speakers. There will be a question and answer session after the presentation. A phone number will be provided in the webinar so you can ask questions via the phone. Adam Richards, Health Insurance Specialist at CMS, will provide an introduction to today's webinar and turn it over to Molly McCarris, Program Lead of the Merit-Based Incentive Payment System, and Benjamin Chen, Health Policy Analyst at CMS, who will talk more about the rule provisions. Adam, you may begin your conference.
Great, thank you, and good afternoon, everyone. This is the Train the Trainer event for the final rule for Year 2 of the Quality Payment Program. We do have a lot of ground to cover today, so I'm going to keep my introductory remarks relatively brief. However, before jumping in, I do want to take the opportunity to thank each and every one of you on the call today for your continued support in helping clinicians prepare for and participate in the Quality Payment Program. While we now have a rule out for Year 2, it is important to remember that there is still a lot of work to do this year to ensure that clinicians are aware of the program, they understand this year's policies, they know that there is still time to participate for the transition year, and they recognize where to go for help and support. So I think we have great representation from our technical assistance organizations, the service center, our regional offices. Certainly our Quality Payment Program clinician champions are on the line today as well, and others. So I want to start us off by certainly thanking all of you for your hard work thus far. Moving on to slide 3. Just some general administrative housekeeping. We will have a question and answer session if time allows following the conclusion of our discussion today. I'll note that we have a number of our subject matter experts on hand in the Q&A feature to try and answer some of your questions as they come in, so please use the Q&A. I'll do my best to look for trends in the chat and try to address these questions as we move through the presentation today. Please note that this is a final rule with comment period, so we also have an interim final rule with comment period. And as always, we do need to protect elements of the rulemaking process, so we will do our best to address straightforward questions, but we do ask you all to submit your comments through the formal process as outlined in the Federal Register and within the final rule itself. We will review some of the elements within the final rule that are open for comment about halfway through our program today. Next slide. Again, please adhere to the formal submission process, and as you're out working with clinicians, other stakeholders, partners, please also remind them to adhere to this process as well when submitting comments on the open items within the final rule. Do note this is a 60-day comment period, and all comments are due by January 2nd, 2018, which I believe is a Tuesday for those who are currently circling through their calendars. Next slide. I also want to take a moment to note a recent change that has kind of occurred simultaneously to the release of the final rule for Year 2 of the program. We have transitioned our resources on the Quality Payment Program to a new resource library on cms.gov. We've provided the links on this slide itself. We do believe that this will make it easier for clinicians to search and find information on the program as we continue to build out qpp.cms.gov, although we certainly encourage all of you to continue using qpp.cms.gov as a central source for the Quality Payment Program, and certainly using the redirect links embedded within to get to the new resource library. Next slide. So we have, like I said, we have a very jam-packed agenda today. We will go through the overview very quickly and then get into the final rule for Year 2 of the program. We'll touch on various aspects of the Merit-Based Incentive Payment System, so an overview, who is included, the performance period, reporting and data submission options, talk a little bit about our performance categories, changes to the threshold and payment adjustment, and then certainly round out with scoring. We also have a good discussion on the alternative payment model side. So we'll talk about advanced APMs, the all-payer combination option, and the APM scoring standard. And then, of course, as time allows at the end, we will go through and address any questions and answers that you may have. So if we jump into slide 8, I won't spend too much time talking about the generalities of this section. Instead, I do want to focus on highlighting some of our points of emphasis for year 2. So we released the final rule for year 2 of the Quality Payment Program on November 2nd. And because we want to keep getting your feedback, this is a final rule with comment period, as I mentioned earlier. In order to get to this point, we did consider quite a few comments, around 1,300 comments from interested stakeholders on the proposed rule for year 2. And we have finalized policies for the second year of the program that will further reduce clinician burden and provide more ways for clinicians to participate successfully. We are going to keep listening, so please encourage clinicians, stakeholders, partners, and others to keep providing feedback to us. You'll also note throughout our time today that we are continuing many of our 2017 transition year policies while introducing some modest changes to ensure that clinicians are ready for full implementation in year 3, which is performance year 2019. I'm sure you all hear from Molly and Ben speak to this notion throughout the discussion. I also want to mention that we understand that this program is a big change, so we've said before we will continue to take this slow. We'll give clinicians more flexibility to help reduce their burden and offer new incentives for participation. We are also going to continue to offer our free direct technical assistance to help clinicians participate in this program. So we do want to continue the good and very appreciated work that you are all doing into future program years. So jumping into slide 9, our considerations have stayed the same. Of course, major focus on reducing burden for clinicians, increasing the adoption of advanced APMs, maximizing participation in the program, and again, for all of you who are supporting us and helping clinicians prepare for this program, certainly awareness is a big part of maximizing participation. This is where many of you play an important role. Of course, improving data and information sharing. We want to ensure operational excellence and deliver IT system and capabilities that meet the needs of our users. But I guess first and foremost, of course, it's improved beneficiary outcomes. So those are our strategic objectives or our considerations, however you want to call them, as we move forward in the program. So at this time, we're going to jump into the merit-based incentive payment system discussion, and I'm going to turn it over to my colleague, Molly McHarris.
Thank you, Adam, and thank you, everyone, for joining us here today. Okay, so let's get started on talking through the MIPS portion of things. As Adam noted, we have made a handful of changes, but we have tried to maintain as much consistency from the first year as possible. So throughout the MIPS portion of the presentation, I'll really try to focus on the areas where we did make changes, and I'll try to go through a little bit more quickly the areas where the policies have remained the same. So as folks can see on slide 11 here, the background of the MIPS program is that prior to the MACRA legislation passing 2 years ago, there were 3 disparate programs that impacted clinicians. Those included the Physician Quality Reporting System, which dealt with quality, the Value-Based Payment Modifier, which measured clinicians on both quality and cost, and then the Medicare EHR Incentive Program for eligible professionals, which dealt with clinicians utilizing certified EHR technology, which is now part of the Advancing Care Information Performance category. So let's move on to the next slide. So as you can tell on this slide, there are the 4 performance categories. One important piece I did want to note for everyone's awareness is that the performance category weights for the second year have changed from where they were at the first year. So in the first year, quality counted for 60 points and cost counted for 0 points. We did make a change within this final rule to have quality count for 50 points and cost count for 10 points. The reason why we made that change is because, as many of you, if not all of you, are aware, beginning in the 3rd year of the MIPS program by law, quality and cost must count each for 30 points. And so we wanted to ensure that clinicians had experience being measured under the cost performance category before it counts for the full 30 points. Improvement activities and advancing care information, those still count for 15 points and 25 points respectively. And of course, that sums up to 100 possible total points, which is the total number of points that a clinician could receive for their final score. And so what exactly is the purpose of assigning a clinician a final score? The final score is what we compare to the MIPS performance threshold. And I'll touch on this a little bit later in the presentation, but the performance threshold for the second year is 15. So any clinician's final score that is above 15, they would be receiving a positive payment adjustment. If it is at 15, they would be receiving a neutral payment adjustment. And if it's below 15, they would be getting a negative payment adjustment. So let's go ahead and move on to the next slide, and then the next slide again, who's included for year 2. So for year 2, there's no change in the types of clinicians that are eligible or able to participate. The same clinician types that were eligible and able to participate in year 1 can continue to do so in year 2. So again, those include physicians, physician assistants, nurse practitioners, clinical nurse specialists, and certified registered nurse anesthetists. And a reminder on the following slide, the definition of physicians, that does include the Medicare definition of physicians, which is broader than just MDs and DOs, but it also includes dentists, podiatrists, optometrists, and chiropractors. Let's move on to the next slide. So who is included based off of the low volume threshold? So we did finalize a change here. So in the first year, the low volume threshold was billings that are greater than 30,000 and 100 patients. We've increased the low volume threshold for the second year to be billings greater than 90,000 and 200 patients. So again, we did make a change here. This is the same change that we proposed from the proposed rule. And what this change does is it further reduces the burden on a number of small practices, rural practices, and solo practitioners by excluding them from the MIPS program. Let's move on to the next slide. So for the rest of our basic exemption criteria, so as many of you will recall, under the MIPS program, we have 3 main areas where clinicians could be excluded. That includes if a clinician is newly enrolled in Medicare, the low volume threshold, and then if a clinician has significant participation in an advanced APM. Beyond the change to the low volume threshold, which I just went over, which is that it's been increased to 90,000 or 200 patients, no changes have occurred for clinicians that are newly enrolled or significant participation. So let's move on to the next slide. Our non-patient facing criteria. And so non-patient facing criteria, so this is a status that we apply to clinicians. And with this status, under some of the performance categories, they have to do a little bit less. So for example, under the improvement activities performance category, non-patient facing clinicians, as well as small practices, rural practices, and HIPSA practices, their activities are double weighted in the improvement activities performance category. So the definition of a non-patient facing MIPS eligible clinician has remained the same in the second year for individuals and groups, but we did finalize the option for clinicians to participate as part of a virtual group beginning in the second year. And so we do have a definition of non-patient facing MIPS eligible clinicians for virtual groups, which is that virtual groups would need to have 75% or more than 75% rather of their NPIs during a virtual group labeled as non-patient facing. Let's move on to the next slide. So just a few other special statuses I wanted to touch on here. Our definition of a small practice, again, that remains the same, that it is a practice consisting of 15 or fewer eligible clinicians. And then our definitions of rural or HIPSA areas, those have remained the same as well, which is that an individual MIPS eligible clinician group or virtual group with multiple practices under its TIN would have to have more than 75% of NPI's billing under the individual MIPS-eligible clinician or group's TIN designated as a rural or HPSA area. Okay, so let's move on to the next slide, and then the next slide again to talk about the performance period. So one of the questions we've received since the rule was released last week was in relation to the performance period and the increase in the time frame of the performance period and how this impacts how clinicians in the first year participated through Pick Your Pace. I do want to clarify that we are continuing to view the second year of the program as a further transition year. We've provided a lot of guidance and information regarding the first year and how clinicians can just do a minimal amount of participation and still avoid a negative payment adjustment. We've continued to do that in the second year with some modest increases, which I'll continue to go over. But clinicians can still participate in the program doing potentially a minimal amount of participation and still meet the performance threshold, and or many clinicians will be able to exceed the performance threshold to get a positive payment adjustment. So the changes that we made from the first year to the second year was increases to the performance period. So in the first year, the performance period for quality was a minimum of 90 days up to a full 12-month performance period. We actually finalized in last year's rule that beginning for the second year, the performance period for quality would count for 12 months, but that the performance period for improvement activities and advancing care would continue to be 90 days. We also did finalize in last year's rule that the cost performance category would also be for 12 months. So let's move on to the next slide. So just a high-level timeline of what performance would look like for the second year. So 2018 calendar year is the performance period. Again, for quality and cost, it's a 12-month performance period. For improvement activities and advancing care, it's any continuous 90-day period during the calendar year. Then clinicians would either submit their data directly to CMS, or they would work with a third party to submit their data no later than the end of March 2019. Then in 2019, we would issue feedback, and then payments would begin being adjusted beginning January 1st, 2020. And the payment adjustment percentage has increased from the second year. This, again, was written into the macro law. So in the second year, the total amount of payment that could be distributed ranges from 5%. In the first year, the total amount was 4%. So let's move on to the next slide, and then the next slide again to go over the data submission options and how clinicians can participate. So as I mentioned a little bit earlier when I touched on that we did finalize our option for virtual groups in this year, there are now 3 main ways that clinicians can participate in MIPS. The first 2 are the same as they were in the first year, which is clinicians can participate as an individual or as part of a group. And then the third option we finalized in this rule is the option for virtual group participation. And virtual groups are made up with a combination of solo practitioners and groups of 10 or fewer eligible clinicians who virtually participate in MIPS for a performance period for a year. Moving on to the next slide. So let's talk about virtual groups in a little bit more detail because I realize that the concept of virtual groups can be a little confusing. So again, a virtual group is any combination of a solo practitioner or 10 or fewer eligible clinicians who come together virtually to participate in MIPS for a performance period for a year. Virtual groups, there's no restriction on the makeup of specialties that are part of a virtual group or location. So virtual groups can really form these groups based off of whatever parameters they see fit, as long as they are in accordance with the criteria we finalized in this year's rule. So again, to be eligible to form a virtual group, clinicians would either need to be a solo practitioner who is considered MIPS eligible. And to be considered MIPS eligible, that means that you would exceed the low volume threshold and would not be considered a newly Medicare enrolled eligible clinician or a QP or partial QP. And then the group side of the virtual group would be a group that has 10 or fewer eligible clinicians that exceeds the low volume threshold at the group level. Okay, and then the next slide for a little bit more information on virtual groups. So solo practitioners and groups who want to form to be a virtual group must go through the election process. The election must occur by law prior to the beginning of the performance period. So by law, all elections must be made no later than December 31st. So the December 31st deadline is an extension from what we had initially proposed in the proposed rule. At that point, we had proposed an election deadline of December 1st. We've since finalized the election deadline will be December 31st for virtual groups. And then moving on to the next slide, some more information on virtual groups. So generally, we treat virtual groups as groups, meaning all group policies, unless they're otherwise noted, would apply to virtual groups. So virtual groups can use all the same submission mechanisms as groups, and they have many of the same other flexibilities that groups do. All clinicians that are within a TIN that elect to join a virtual group are part of the virtual group, and virtual groups would be required to aggregate their data for a given performance category across the virtual group. And then they will be assessed and scored at the virtual group level for purposes of MIPS. So again, for each of the 3 performance categories where data submission would be required, quality, improvement activities, or advancing care information, we would be looking for the virtual group or their third-party intermediary to have their data aggregated across the virtual group, and we would calculate their performance based off of that data submitted. One other piece I want to note is that if a TIN MPI, so if a clinician is participating in both a virtual group and as part of an APM, the TIN MPI, the clinician, would receive a final score based on the virtual group performance and a final score based off of performance in the APM. Based off of our waiver authority, however, the clinician would receive their final score based off of their participation in an APM. And then for the next slide, so how do you make an election to be part of a virtual group? There's a 2-stage election process, and remember the deadline for this election process is December 31st. The first stage is optional but encouraged, and this is where solo practitioners or groups can choose to contact their local technical assistance organization to see if they're eligible to join or form a virtual group. And then the second stage is that for those virtual groups that did not participate in the first stage, the virtual groups, they will contact us and we will see if they're eligible to be in a virtual group during the second stage. And then moving on to the next slide. So how can virtual groups tell us that they want to participate? So again, the virtual groups, they must make their election by December 31st of this year. The election must include a formal written agreement between each of the virtual group members before the election, and we have included a model agreement as part of our virtual group toolkit. The virtual group must also name an official representative who emails the group's election to the email address on the slide here, which is MIPS_virtualgroups@cms.hhs.gov. And as part of that election package, the virtual groups would need to have information about each of the TIN and MPIs associated with the virtual group and the virtual group representative's contact information. And again, more information on how clinicians can form virtual groups is available on the Virtual Group Toolkit. Let's move on to the next slide. So information on the submission mechanisms. So again, no changes here in the submission mechanisms that are available from year 1 to year 2. All of the same submission mechanisms are available. I did want to note that beginning in the 3rd year of MIPS, so beginning for the 2019 performance period, our clinicians and groups and virtual groups would be able to use multiple submission mechanisms within a performance category. This was something we had proposed this past year to begin effective in the 2nd year. However, due to a variety of reasons, that will not be beginning in the 2nd year, rather it will be beginning in year 3. So let's move on to the next slide, and then next slide again to start digging into the 4 performance categories. So the first performance category is quality, and as you can note on the left-hand side of the slide, there's some basics here, and these basics have remained the same. The only change in the basic information for the quality performance category is that the weight to the final score previously was 60 points, now it's 50 points. And then looking at the table that's as part of this slide, the data completeness criteria has changed in the 2nd year from 50% now to 60%. So let me just repeat that again because I don't want folks getting confused on how we've switched the weight to the final score from 60 to 50 and then the data completeness from 50 to 60. So to say it one more time, the weight to the final score, so this is the total amount of points that would contribute towards a clinician's final score. In the 2nd year, quality is 50 percentage points. Again, cost would be 10 points, improvement activities would be 15 points, and advancing care would be 25 points. Then the data completeness criteria, and data completeness deals with, on a measure-by-measure basis, the data completeness threshold that we are looking to see for the number of eligible patients that a measure was reported on. So in the 2nd year, the data completeness criteria is 60%. For measures that fail data completeness, so if a clinician only reports a given measure for 40% of their patients, not for 60%, then they would receive only 1 point unless the clinician is part of a small practice, and then they would continue to receive 3 points. Let's move on to the next slide. So some of our scoring changes. Again, there's no changes in the 2nd year here. So all of our policies we had in the 1st year, that there's a 3-point floor for measures scored against a benchmark, 3 points that are available for measures that do not have a benchmark or do not meet case minimums, and our bonuses for reporting on additional high-priority measures or utilizing end-to-end electronic reporting. All of those still remain in the 2nd year. No changes were made there. And then let's move on to the next slide to talk about topped-out measures. So let's first start with what is a topped-out measure and why is that important. So a measure may be considered topped out if meaningful distinctions and improvement in performance can no longer be made. Topped out measures can have an impact on the scores for certain types of MIPS-eligible clinicians and provide little room for improvement for the majority. So in this year's rule, we finalized a number of topped out policies. The first is a timeline for identification and removal of a topped out measure. And so that timeline for identification and removal of a topped out measure is 4 years. And this we feel will provide clinicians, third parties, and measure developers an appropriate amount of time to work collaboratively to develop new measures that have additional room for improvement. Topped-out measures with measure benchmarks that have been topped out for at least 2 consecutive years will receive a 7-point scoring cap. So again, remember, generally our measures, clinicians can receive up to 10 points for a measure outside of bonus points available. For measures that are identified as topped out, they would receive a 7-point scoring cap, again, as long as the measure has been considered topped out for 2 consecutive years. We did finalize in this year's rule 6 measures that would start receiving the scoring cap beginning in this second year, and we'll go to that slide in just 1 minute. For the overall removal of topped-out measures, we do have the 4-year timeline that I've described, but we will also take into consideration other performance data available and other considerations. And then lastly, our topped-out policies do not apply to the CMS web interface submission mechanism, but this is an area that we will continue to monitor over time. And so then moving on to the next slide. So the 6 topped-out measures are reflected here. Okay, so let's go ahead and move right along to the cost performance category. So some changes here for the cost performance category. The major change for cost is that we are now measuring cost. Cost will count, again, towards 10% of a clinician's final score in the second year. Again, in the first year, there was no cost measurement. The measures that we are using for the cost performance category are the same measures that we had finalized last year's rule, and these measures were also used under the physician value modifier program. So those measures are the Medicare spending per beneficiary measure and the total per capita cost measure. We had, for the transition year for 2017, finalized 10 episode-based measures, but as folks will recall in this year's proposed rule and then in the final rule, we did not finalize those additional 10 episode measures. We're currently working on developing new episode-based measures that have significant clinician input and involvement that we believe will be much more meaningful to clinicians than the current set of 10 episode measures. Any additional cost measures that we use in the future will be addressed through future rulemaking. And so let's move on to the next slide. So the information on this slide, on slide 37, this is all the same as what we had finalized for the first year, but since cost in the second year, cost will be this will be the first time that we're measuring clinicians on cost. I did want to go over this. So the reporting scoring for how cost works is that each individual MIPS-eligible clinician and group's cost performance will be calculated using administrative claims data if they meet the case minimum of attributed patients. So what that means is that no separate data submission is required to be measured under cost. We will perform all of the analyses required based off of your Part B claims data. Performance is compared against performance of other MIPS-eligible clinicians and groups during the performance period, so benchmarks are not based on a previous year. That's different when you think about the way under the quality performance category, we do establish benchmarks ahead of time. The performance category for cost is an average of the 2 measures, Medicare spending per beneficiary and total per capita cost. If only one measure can be scored for a given clinician or group, that would serve as the performance category score. If none of the measures can be scored for a clinician, if we cannot calculate the MSPB or total per capita cost measure, then the 10 points that would normally be attributed to cost would be redistributed to the quality performance category. So that means that for some clinicians, their quality performance category will continue to be 60 points in this second year. So let's move on to the next slide to talk about scoring improvement for quality and cost. So again, by law, in the second year of the program, we are required to measure a clinician's improvement on how they performed on the performance categories and measures in comparison to a prior period. So for quality, improvement scoring will be based on the rate of improvement, such that higher improvement results in more points for those who have not previously performed well. Under the quality performance category, again, we're measuring improvement at the performance category level, and there's a total of up to 10 percentage points available. For the cost performance category, improvement scoring will be based on the significant or statistically significant changes at the measure level, so at the MSPB and total per capita cost measure. And only up to 1 percentage point is available in the cost performance category for improvement. So let's move on to the next slide to start talking about the improvement activities performance category. So again, for the improvement activities performance categories, you can see the basics. No changes there. It still counts as 15% of the final score. There are activities available within the inventory that are medium or high weighted. And then a simple yes is all that is required for clinicians to participate in the improvement activities performance category, whether that be through attestation or through using a third-party intermediary. We did finalize for patient-centered medical terms that we also finalized the term recognized as being equivalent to the term certified for patient-centered medical homes. And we also finalized that for clinicians that are part of groups, the 50% of practice sites within a TIN or TINs that are part of a virtual group would need to be recognized as a patient-centered medical home to receive the full credit for improvement activities in 2018. Again, if clinicians are participating as individuals, the individual would just have to be part of a patient-centered medical home. But if clinicians are participating as part of a group or a virtual group, 50% at the practice site would need to be considered a patient-centered medical home. Moving on to the next slide. We did finalize some additional improvement activities, and we also made a handful of changes to some of the improvement activities. And then for scoring, again, the way that clinicians are scored under improvement activities is the same as it happened in the first year. We have a number of improvement activities where clinicians can earn additional bonus points under the Advancing Care Information Performance category. And again, a simple yes is all that is required to let us, CMS, know what improvement activities have been completed. So let's move on to the next slide to talk through the Advancing Care Information Performance category. So again, starting on the left-hand side of the slide, the basics here have remained the same, which is that the Advancing Care Information Performance category will count for 25 points towards a clinician's final score. It's comprised of a base score, a performance score, and then bonus points. Those total number of points can exceed 100, but they would get scaled down to 100 points to potentially earn up to 25 points towards a clinician's final score. We also are continuing to promote patient engagement and the electronic exchange of information using certified EHR technology. And since we have continued to allow clinicians to use both 2014 or 2015 edition certified EHR technology, there are 2 measure sets available. So then moving to the main body of the slide, again, to touch on the certified EHR technology edition requirements, clinicians can still use either 2014 or 2015 edition cert, but if clinicians use exclusively 2015 edition cert, they can receive a 10% bonus. For the measures and objectives, we did finalize exclusions for the e-prescribing and health information exchange measures. Under scoring for advancing care information, again, no changes to the base score requirements for the second year. For the performance score, MIPS-eligible clinicians and groups can earn 10% for reporting to any one of the public health and clinical data registry reporting measures as part of the performance score. And then for the bonus score, a 5% bonus is available for reporting to an additional registry not reported under the performance score. And again, as I've noted prior, we do still continue to have improvement activities that have been designated where clinicians can receive up to a 10% advancing care information activity bonus. So let's move on to the next slide. So a handful of exceptions that have changed for the second year. The first is that we've utilized a different statutory authority based off of what was granted to us using the 21st Century Cures Act. So we will reweight the advancing care information performance category to 0 and reallocate that weight to the quality performance category for a handful of reasons. There are automatic reweighting reasons. The first is if a clinician is considered to be hospital-based, and that continues to be the same as how it occurred in the first year, but we did finalize an additional place of service code. We also finalized that for clinicians that are considered to be ambulatory surgical center-based, that they would have automatic reweighting. I also want to note that this policy has been applied to the 2017 year as well. And again, that's based off of the language within the 21st Century Cures Act. So again, for clinicians that are ambulatory surgical center-based, even though we didn't have this exemption in last year's rule, due to the language within the 21st Century Cures Act, clinicians that are ambulatory surgical center-based in 2017 will still have this automatic reweighting applied to them, and it will continue in the 2018 year. And then, again, if a clinician is considered to be a nurse practitioner, physician assistant, clinical nurse specialist, or certified registered nurse anesthetist, they would have automatic reweighting. And then the reweighting that is new for clinicians that could happen through an application. So we have a new hardship exception for clinicians that are in small practices. And again, our definition of a small practice is 15 or fewer eligible clinicians. We also have a hardship exception for clinicians whose EHR has been decertified, and that also has been applied to both the 2017 year and the 2018 year. And then we will not be applying a 5-year limit to these exceptions. And then lastly, there is a new deadline of December 31st for the performance year for all applications to be received. And again, this applies both for the 2017 year and future years. So let's move on to the next slide. And then the next slide again on slide 44. So just a few more MIPS items, and then I can turn it over to Ben to talk about the APM side of things. So to talk through the performance threshold and payment adjustment. So as slide 44 reflects, there was a slight increase to the performance threshold and payment adjustment. The performance threshold is increased from 3 points in year 1 to 15 points in year 2. The exceptional performer threshold is still set at 70 points. And as I noted earlier, the payment adjustment percentage is now 5%. In the first year it was 4%, and that's a change based off of what the law requires us to do. And then at the bottom of slide 44, there's a handful of examples on how a clinician can get to 15 points. So those include reporting everything that's required under the improvement activities performance category, meeting the advancing care information performance category base score, and then submitting one additional quality measure that meets data completeness criteria, meeting the advancing care information performance category base score, and then submitting a medium-weighted improvement activity, and then submitting 6 quality measures that meet data completeness criteria. Again, this is just a handful of examples of how a clinician can achieve 15 points. There are many other combinations available on how a clinician can get to 15 points. So let's move on to the next slide. So this provides a chart of what I just went over related to the performance threshold. So just looking at the right-hand side of the slide for the second year, starting from the bottom up, so 0 points. So if a clinician has 0 points, the negative payment adjustment of negative 5% would apply to them. If they have 15 points, they would be getting a neutral payment adjustment. if they have between 16 and 69 points, they would be getting a positive adjustment, but they're not eligible for the exceptional performer bonus. And then if they get greater or equal to 70 points, they would get the MIPS positive adjustment and also eligible for the exceptional performer bonus. Let's move on to the next set of slides, scoring. So I'll start on slide 47. So calculating the final score. So again, what does all of this mean? How does this get tied up together? So again, performance on the 4 performance categories make up a clinician's total final score. And again, that final score, that number, is compared to the performance threshold, and then how that number compares to the performance threshold, if it is above it, below it, or at the performance threshold, that determines if a clinician will receive a negative, positive, or neutral payment adjustment. So moving on to the next slide to talk about the complex patient bonus. So the complex patient bonus is a new bonus set of points that we have available beginning in the 2nd year. We recognize that a number of clinicians treat patients that are both medically complex and are considered to be dual eligible. So there is up to 5 bonus points available for treating these complex patients. To receive the bonus, MIPS-eligible clinicians, groups, and virtual groups would need to submit at least something for one of the performance categories. And I do want to note on the complex patient bonus, the total amount of bonus points available that will be calculated once we receive all data. So it could range between 1 to 5 bonus points. Then moving on to the next slide, the small practice bonus. So for the small practice bonus, this will just be a flat 5 points that will apply to any and all small practices. And again, a small practice is 15 or fewer clinicians, as long as they participate in one of the MIPS performance categories. And we implemented this small practice bonus because we recognize that even with all of the changes we've tried to make to the program to make it more flexible for clinicians to participate, we recognize that a number of small practices still have challenges in participating in the program. So we wanted to further encourage those small practices to participate. Okay, let's move on to the next slide for facility-based measurement. Our facility-based measurement policies, this was a proposal that we made for clinicians that practice medicine as part of facilities, and it is an option for clinicians where it could more appropriately be used for their quality and cost performance categories. Unfortunately, due to operational constraints, we are not able to offer facility-based measurement in the 2nd year. It will begin, however, in the 3rd year. So for facility-based measurement, again, I won't go over this in too much detail, but facility-based measurement will be available in the 3rd year. If technically feasible, we do intend to provide informative feedback to clinicians who could be part of facility-based measurement in the 2018 year, and we will make additional proposals related to facility-based measurement in next year's rulemaking process. Then moving on to the next slide for extreme and uncontrollable circumstances. So as part of this year's final rule and then the associated interim final rule, we felt it was necessary to provide guidance and information on how clinicians that have been impacted by the recent hurricanes, including Harvey, Irma, and Maria, on what they have to do for participation under the quality payment program. So as part of the interim final rule that was issued for clinicians that have been impacted by hurricanes Harvey, Maria, and Irma in the 2017 year, they will, if they are part of a FEMA major designated area, they will automatically receive a final score equivalent to the performance threshold. No separate application is required. We will use the clinician's practice address that is available within PACOS to make the determination. And again, they would be receiving a final score equivalent to the performance threshold. If clinicians that are in one of these affected areas submit data, then we would calculate that data and attempt to calculate a final score based off of the data received. And then on the next slide, our extreme and uncontrollable circumstances policy for the second year. So again, this will still continue to be available, but in the second year, we weren't able to finalize a no hardship application process. So for the second year, clinicians would need to file a hardship application no later than December 31st of 2018 if they have an extreme and uncontrollable circumstance. And then let's move on to slide 54. I just wanted to briefly flag the policies that we are seeking additional comment on. So as you can tell on slide 54, there's a handful of policies on the MIPS side of things that we're looking for additional information on, including ways that we should define a group, the low volume threshold, potential new standards for QCDR measures, any feedback folks have on a simpler scoring approach for MIPS, bonuses and ways that they could be further aligned across the quality payment program, and then of course the interim final rule. So at this point, let me go ahead and turn the presentation over to my colleague Ben to talk about advanced alternative payment models. Ben?
Thanks, Molly. And so now we'll move on to discuss the policy changes for year 2 that will affect the advanced APM track of the quality payment program. Next slide. So as a refresher, the macro statute defines APMs fairly broadly to include all CMS Innovation Center models, the Medicare Shared Savings Program, and any demonstrations under the Healthcare Quality Demonstration Program, and any other demonstrations required by federal law. To be an advanced APM, a model must meet 3 requirements, which we finalized in last year's rulemaking. First, it must require participants to use certified EHR technology. Second, it must provide that payments for covered professional services are based on quality measures comparable to those used in the MIPS quality performance category. And third, it either is a medical home model expanded under CMS Innovation Center authority, and I'll note that to date, no such model has been expanded under Innovation Center authority, or it requires participants to bear more than a nominal amount of financial risk. In order to qualify for a 5% APM incentive payment, model participants must receive a certain percentage of payments for covered professional services or see a certain percentage of their patients through an advanced APM during the associated performance year. So in last year's final rule, we established standards for the criteria just described, and in general, we are keeping those standards but are finalizing a few changes. Next slide. In last year's final rule, we finalized 2 ways that APMs could meet the generally applicable nominal amount standard criterion. APMs can meet the nominal amount standard if total potential risk under the APM is equal to at least either 3% of the expected expenditures an APM entity is responsible for under the APM, which was finalized for all performance years, or 8% of the average estimated Parts A and B revenue of providers and suppliers in participating APM entities, which we only finalized for the 2017 and 2018 performance periods. So we are finalizing extending the 8% revenue-based nominal amount standard for an additional 2 years through performance period 2020. Moving on to the next slide. In addition to the general nominal risk standard, last year we also finalized a separate definition of a medical home model that only applies to the quality payment program and a special financial risk criterion specifically for medical home models. We finalized 2 changes related to the special medical home model financial risk criterion, which I will discuss over the next couple of slides. Next slide. So last year it was finalized that starting in performance year 2018 and thereafter, the medical home model financial risk standard but only apply to APM entities in advanced APMs with fewer than 50 clinicians in their parent organization. So this year we finalized to maintain that standard with a limited exception. Specifically, we are proposing to exempt, or we're finalized to exempt round 1 participants in the Comprehensive Primary Care Plus model from the requirement that the medical home model financial risk standard only applies to APM entities with fewer than 50 clinicians in their parent organization. All future CPC Plus participants will be subject to the 50 clinician cap, so the 2018 starters in CPC Plus will be subject to this policy. Moving along, next slide. We're also finalizing one additional change to the medical home model nominal amount standard. In last year's final rule, we finalized that the total potential risk for an APM entity must be equal to at least 3% in 2018, and that it would gradually ramp up to 5% in 2020 and thereafter. We are changing the nominal amount standard for medical home models so that the minimum required amount of total risk increases more gradually, maintaining the standard at 2.5% in 2018, and then ramping up to 5% in 2021 and thereafter. We believe this approach may allow for greater flexibility and encourage more participation in medical home models and be more sustainable for the type of APM entities that would potentially participate in medical home models. Next slide. So now we'll discuss the changes that we made to the all-payer combination option and other payer advanced APMs. So moving along to the all-payer combination option, this option, along with the Medicare option, is one of 2 pathways through which eligible clinicians can become a QP or a partial QP. Beginning in performance year 2019, QP determinations under the all-payer combination option are based on an eligible clinician's participation in a combination of both advanced APMs and other payer advanced APMs. And it is important to note that QB determinations are conducted sequentially so that the Medicare option is applied before the all-payer combination option, and only clinicians who do not become QPs under the Medicare option will have the opportunity to participate in the all-payer combination option. Next slide. So moving along to how we will make other payer advanced APM determinations. Last year, we finalized that eligible clinicians or APM entities on their behalf would report information about the payment arrangements they participate in after the 2019 QP performance period. This year, we established a process for payers to submit information to CMS regarding non-Medicare payment arrangements prior to a given QP performance period so that CMS can determine whether the payment arrangement meets the criteria to be an other payer advanced APM. This payer-initiated process would be available for Medicaid, Medicare health plans, and CMS multi-payer models for performance year 2019, and we do intend to add remaining payer types in future years. Next slide. And so just to reiterate here, the payer-initiated process would be voluntary. Payers would be able to request review of multiple other payer arrangements through the payer-initiated process, though CMS would make separate determinations as to each other payer arrangement. And like in the payer-initiated process, APM entities and eligible clinicians would also have an opportunity to request determinations of other payer arrangements they participate in, but that process would take place after each QP performance period. Guidance and submission forms for both payers and clinicians are going to be made available for each payer type early in the calendar year prior to each all-payer QP performance period. The specific deadlines and processes for submitting payment arrangements will vary by payer type in order to align with pre-existing processes and meet statutory requirements. Next slide. So switching gears a bit and moving on to the other payer advanced APM criteria. So we finalized last year that the criteria for determining whether a payment arrangement qualifies as an other payer advanced APM are similar but not identical to the criteria used within Medicare. And the first criterion is it requires at least 50% of eligible clinicians use certified EHR technology. Second, that payments for covered professional services are based on quality measures comparable to those used in MIPS. And third is either a Medicaid medical home model that meets criteria comparable to medical home models, or they require participants to bear more than a nominal amount of financial risk. We did make some changes, so moving on to the next slide. For the generally applicable nominal amount standard for other payer advanced APMs, we finalized that the nominal amount of risk must be meet 3 elements of risk, so the marginal risk of at least 30%, the minimum loss rate of no more than 4%, and a total risk of at least 3% of the expected expenditures the APM entity is responsible for under the terms of the APM. This year, we're maintaining the marginal risk and the minimum loss rate requirements, but we're also adding a 8% revenue-based nominal amount standard that would apply to models in which risk for APM entities is defined in terms of revenue. This would be an additional option. It would not replace or supersede the expenditure-based standard previously finalized last year for other payer advanced APMs. Next slide. So moving on to QP determinations under the all-payer combination option. Last year, we finalized that QP determinations would be made at either the APM entity level as we make them under the Medicare option. We finalized this year that QP determinations will be made at the individual eligible clinician level or the APM entity level. Also, like in the Medicare option, the QP performance period for the all-payer combination option would run from January 1st to August 31st of each performance year. Next slide. So on the next 2 slides, you provide a high-level overview of the timeline for other payer advanced APM determination. Again, guidance and submission forms for both payers and clinicians will be made available for each payer type early in the calendar year prior to each all-payer QP performance period. For Medicaid, both the payer and eligible clinician-initiated processes will take place in calendar year 2018. For the payer-initiated process for Medicaid, the submission form will be available in January with a submission deadline in April. And for the eligible clinician-initiated process for Medicaid, the submission forms will be available in June with a submission deadline in November. Again, for Medicaid, prior to the start of the relevant all-payer QP performance period, we intend to post the other payer advanced APMs that we determine through the payer-initiated process and the eligible clinician-initiated process are other payer advanced APMs under Title 19. For CMS multi-payer models, that second time on there, the payer-initiated process will first take place in 2018. Submission forms will be available in January with a submission deadline in June. And we will post an initial list of other payer advanced APMs we determine through this process in September. For the eligible clinician-initiated process for CMS multi-payer models, submission forms will be available in August of 2019 and are due at the beginning of December in 2019. An updated list of other payer advanced APMs we determined through this process will be posted by the end of December in 2019 before all payer QP determinations are released for that year. Next slide. And so for Medicare health plans, and that timeline on the top of the slide, the payer-initiated process will first take place in 2018. It will be run in conjunction with the Medicare Advantage bidding process using HPMS. Submission forms will be available in April as part of the HPMS bid package with a submission deadline of June. We will post a list of other payer advanced APMs determined through this process in September. And for the eligible clinician-initiated process, submission forms will be available in August of 2019 and are due at the beginning of December of 2019. And an updated list of other payer advanced APMs determined for Medicare health plans determined through this process will be posted by the end of December 2019, again, before all payer QP determinations are released. For remaining other payer arrangements, mainly commercial arrangements, determinations will not be made prior to performance year 2019. We do intend to add this option in future years, however, it will not be an option in 2018. However, there will be an eligible clinician-initiated process for the remaining other payer payment arrangements, and submission forms will be available in August of 2019 and are due at the beginning of December in 2019. And again, an updated list of other payer advanced APMs will be posted by the end of 2019 before all payer QP determinations will be released. Next slide, and advance it one more. So now we'll be moving on to the APM scoring standard for MIPS APMs. And as a reminder, the APM scoring standard was finalized last year and offers a special, minimally burdensome way of participating in MIPS for eligible clinicians in APMs who do not meet the requirements to become QPs and are therefore subject to MIPS, or for eligible clinicians who meet the requirements to become partial QP and therefore able to choose whether to participate in MIPS or not. The APM scoring standard applies to APMs that meet these three criteria: that they have APM entities that participate in the APM under an agreement with CMS, they have APM entities that include one or more MIPS eligible clinician on a participation list, and they base payment incentives on performance, on cost utilization, and quality measures. Next slide. Last year, we finalized different scoring weights for the quality performance category for ACO models, including the Medicare Shared Savings Program and the Next Generation ACO model, compared to other MIPS APMs, which held a quality weight to 0. So for performance year 2018, we are aligning the quality performance category weighting across all MIPS APMs and will assess all MIPS APMs on quality. Next slide. We also finalized additional details on how the quality performance category will be scored under the APM scoring standard for other MIPS APMs. In 2018, participants in these models will be scored under MIPS using quality measures that they're already required to report on as condition of their participation in their APM. So participants in those models would not be required to separately report any quality information as a part of MIPS. We also finalized another significant change under the APM scoring standard, which is adding a forced snapshot date of December 31st for Fulton APMs for the purpose of determining which eligible clinicians are participating in a MIPS APM. And to be clear, this would allow participants who joined certain APMs, mainly the Shared Savings Program, between September 1st and December 31st of the performance year to benefit from the special APM scoring standard. And that concludes the discussion of policy changes for the advanced APM track. And so now I'll turn it back over to Adam to talk about additional resources and technical assistance.
Thanks, Ben. Appreciate that. We're going to go, we go into the next slide. I think this is our technical assistance slide. We won't spend too much time on this. Again, just reiterating that we are continuing our free technical assistance to clinicians participating in the program for both year 1 and year 2, and certainly the future program years. So please, as you're out, use this infographic for clinicians. I am going to move quickly through the next few slides because we do want to get to the Q&A portion. So if we go to the next slide, please. Okay, once again, this is just a reminder about submitting your comments for the final rule. Again, 60-day comment period. The comments are due January 2nd, 2018, so please share that information with clinicians, stakeholders, partners. And of course, all the instructions for submitting comments are included in the rule itself as well as on the Federal Register. So we'll move to the next slide. And we are going to open it up for our Q&A session. I know a number of you have been sending us questions and comments through the chat, so we appreciate that, and we are trying to answer those as quickly as possible. But we are going to open up the phone lines at this time. Please remember that this is a final rule with comments, so any questions on some of the areas that we are seeking comment, we'll try to talk about as best we can, but we do encourage you to submit those comments directly to us through the official process outlined in the Federal Register and certainly in the final rule. So at this time, we're going to open up the phone lines for your questions. We'll also take a look through the Q&A at this time as well, just to see what we can pull while we're waiting for the phone lines to fill up. Do we have anyone on the line right now? Operator, do we have anyone on the line?
At this time, if you would like to ask a question, please press star, then the number 1 on your telephone keypad. Again, that's star, then the number 1 on your telephone keypad to ask a question. Please hold for the first question.
Okay, great, thanks. I just want to mention, because we are getting a couple of comments and questions in the chat itself, we will be providing a copy of the slide deck as well as a recording. We ask that you do just give us a few days. It does take just a few days to turn the recording around, but we will make sure that you have all the documents that were presented today. I know we did move through the information very quickly. There's a lot of information, so you will have those resources very soon. And I'm going to turn it back over to the line. Do we have anyone on?
We do have a question from Brian Warren has a question.
Hi, actually, this is Sandy Swallow, but I have a question. If you would elaborate just a little bit more on the ACI category with that HIE exclusion. If you are participating as a group practice and you have one of your, say, I'm going to just use a scenario, so say you have 8 eligible clinicians, MIPS eligible clinicians, and one of them meets the criteria for the HIE because they don't even do transitions of care. Would you or would you not select that as an exclusion, or would that not really matter because you're going to aggregate the data together for that group practice, that 10 group? I don't know if that made sense to you, but it did to me.
Okay, so for the advancing care information, in order for you to claim the exclusion, the entire group would need to exclude, but if several providers fit the definition for the exclusion, you just would not include their data when you aggregate the data for the measure.
Okay, so you would just not, you wouldn't use that exclusion because you have several providers that do meet, that don't meet that exclusion, and you have numerators for them that are greater than 1. Okay, thank you. That was kind of where we were going, but wanted to make sure.
Okay.
Again, if you would like to ask a question, please press star, then the number 1 on your telephone keypad. That's star, then the number 1. There are no additional questions in the queue.
Wow, fantastic. So again, we'll just keep it open for a few more minutes in case anyone has any additional questions. We are just I'm taking a look through the Q&A right now. I know, like I said, our subject matter experts are working fast and furiously through some of these questions that are still outstanding. But if we do have any that are out there, I will ask our team just to flag these for us. And certainly you can continue to send in, your questions to us. Once again, we will be sending out the slide deck as well as a recording of this webinar to those who were on the call so that you have these resources moving forward. Do we have anyone on the line right now?
There are no questions at this time.
Okay, great. And once again, I'm just taking a look through the Q&A at this point, looking for outstanding questions. I think our subject matter experts have done a great job, so I do want to thank each and every one of you for being on today, certainly answering the questions in the chat. Again, just as a reminder that this is a final rule with comments, so as you're out working, please let clinicians, partner stakeholders know that we do have that option available. 60-day comment period is open, and those comments are due January 2nd, 2018. we are going to continue to work through some of the Q&A for the remainder of the time, but if we don't have any more questions on the phone line.
We do have an additional question from Jane Doobie. Jane, go ahead with your question.
Okay. I understand that there is not the test participation option in 2018. However, there seem to be a whole variety of options for participation to achieve the 15 points for a neutral payment adjustment. Is this somewhat taking the place of the test participation?
Sure, this is Molly. So I would say that we are still viewing the second year of the quality payment program as a transition year. So as folks know, in year one, in the transition year, we had the pick your pace approach, which allowed clinicians to participate in the program either in a test manner, a partial manner, or a full manner. And the test option was where clinicians could report on one measure or one improvement activity or just the base elements of the Advancing Care Information Performance category and avoid a negative payment adjustment. In the second year, again, we have extended the flexibilities for participation where clinicians can participate, still doing, a minimal amount of participation to avoid that negative payment adjustment. We haven't called it in the second year as a continuation of pick your pace with the test option or the partial option or the full option, but we are still continuing to view the second year as a transition year. So again, as I noted on one of the slides prior, there's a number of ways that people can get to that 15 points. And the options I gave on the slide earlier, I think it was just 3 or 4 examples. There's many, many more examples on how a clinician could still test or partially participate in the program and avoid that negative payment adjustment. I hope that helps. Thank you.
Yes, thank you. A follow-up question to that would be, so we have the full participation basically option this year, and then they have the choices for achieving 15 points for a neutral adjustment. So kind of the 90-day participation is the one that has been dropped?
Well, there is still 90-day participation for improvement activities and advancing care.
Yeah.
In the first year, there was 90 days for quality improvement activities and advancing care. Now, in the second year, quality, as you know, there's a 12-month performance period there. But, again, when you look at the various ways that clinicians participate and the amount of points that clinicians would receive, even if they fail data completeness or if they don't have the appropriate case minimum, they still earn a certain number of points toward the given performance category. I wouldn't necessarily characterize the second year as full participation only. Again, the way that we're really thinking about it is that it's another extension of the transition year. There have been some modest changes to slightly increase the requirements. Again, as we start looking at the legal requirements that the program must meet beginning in the third year that we really want to make sure that clinicians are prepared for. Thank you.
Okay, great. Thank you. Last call for questions on the phone line.
We have another question from Tammy McNeil.
Hi, thank you. So there was a slide that referenced something in the improvement activities that was changing regarding patient-centered medical home. I think it stated that you were expanding it from just certified programs to recognized programs, if I have the terminology correct. So I'm curious, if that means that, you know, the 4 or 5 programs that are certified now, if you're going to be adding to that, and they don't have to go through maybe the same steps. My concern is, in the past we've had some payer PCMH programs that have said that they count in the improvement activities category, and so I think there's been some confusion on that. So can you just clarify that for me?
Sure, that's a great question. So to be considered a patient-centered medical home, those organizations would still need to meet the criteria that we had defined in the rule, actually in last year's rule, for the first year. All we're doing with adding this term recognized is some of the stakeholder feedback we heard after last year's rule was published, and based off of, you know, everything that we've heard when we went into the proposed rule, we wanted to let people know that there is the term certified patient-centered medical homes, but that we also believe that the term recognized patient-centered medical homes or a comparable specialty practice, that term recognized should continue to be included. But again, with that being said, any certified patient-centered medical home or recognized patient-centered medical home would need to meet the criteria of what we designated the patient-centered medical home should be.
Okay.
I apologize, I don't have that list of all of that set criteria in front of me, but I know we highlighted that in last year's rule, and I believe we have it in one of our fact sheets.
Thank you.
Thank you.
We have another question from Cy Lazarus. Mr. Lazarus, go ahead with your question from CMS.
Hi, yeah, I just have a question in regards to if you have a small practice who does not meet the criteria of billing $90,000 or 200 patients, will they be exempt? And if so, how would they be paid, or would they be penalized?
Sure, so let me just make sure I've got your question right. So if there is a clinician that's part of a small practice, how does the low volume threshold apply to them? Could you restate the question? I just want to make sure I'm understanding it correctly.
Yeah, I guess the question would be, would they be paid through value-based? We've had this question come from one of our networks. Would they continue on the value-based payment with no negative or positive adjustment, or would they be continuing at fee-for-service, or is fee-for-service going away totally?
Okay, sure. So if clinicians are excluded from MIPS, then they would not be receiving a MIPS adjustment. So that means they wouldn't be getting the positive adjustment or the negative adjustment. They wouldn't be getting any adjustment. They would, you know, participate in Medicare under fee-for-service, and their claims would be processed accordingly. And that would be regardless if the clinician or group of clinicians in question is a solo practitioner, a small practice, or if for whatever means that they are excluded from the program.
Thank you.
Thank you.
There are no additional questions at this time.
Okay, great. Thank you. We are getting close to the bottom of the hour, so I do just want to take the opportunity to thank everyone for participating today. I know that our subject matter experts are still working through some of the questions in the chat, but they've done a great job in responding to a lot of your questions. Again, if you do have questions, please just send them to us. We'll try to get them answered as best we can within the time that is remaining. Again, I do want to thank everyone for being here today. We do have an upcoming public webinar next week that will talk about the final rule. Again, a lot of the information that you heard today, but I do want to make sure that you are all aware that there is a public webinar next week and that you're sharing that information with the clinicians with whom you're working. Otherwise, we appreciate your time. Thank you for being here, and we'll talk to you again soon.
Thank you. This concludes today's conference. You may now disconnect. Speakers, please hold the line.